Welcome to Sirens Stethoscopes. I'm your host, Kevin, and today we're talking about using vasopressors to manage shock. So let's get into it. Today we are discussing shock and managing shock with medications, specifically vasopressors. And joining us for this discussion to get through this material, Captain Jake Martin. Thanks, Jake.
Thanks for having me.
Glad to have you here. Before we dive too far into this material, some of these ideas and some of the why questions that we love to ask, let's talk about you. Tell us some of the professional background, the experience you're bringing to today's discussion.
Yeah. Seeing that it's taken me 6 months to get on a podcast with you, I'm like the third best captain out of the three of us. So
one of the top three.
Top three, right? Other than that, we've had about 16 years of field experience running with 911 EMS. Done it on the fire side, done it on pure EMS side, done it from all different avenues of it. So it's fun to see the progression of where things are going compared to when I started 16 years ago versus now. So to just be talking about levofed now versus what I heard it about 16 years ago, like it's funny to see that transition occur already.
I love it. And your position as a captain, you, sometimes to your dismay, is a step back from direct clinical care and application. That you're not the one doing all the doing. And in fact, the expectation you have on you in your position is this mentoring, coaching role. So as we talk about procedural things, that yes, you need to be spun up on procedures, and there are some opportunities for you to do it. But the bigger responsibility you carry as a captain is that mentoring and coaching role, that kind of oversight role. How do you feel? What do you like about that? What do you not like about that?
I love the job, right? So I always want to get my hands into everything I possibly can. So it's difficult to step back. So anything that's new that we tend to implement, I always like to do. Like, let me show y'all one or two times the way I got taught. Let me see the way I want you to do it a few times. And then I'll step back and let you do it on your own without any type of interjection unless it's necessary. So it's still very hard. I tend not to grab gloves or put gloves on when I get out of the car just to make sure I'm one step away from being involved right away. Like, it takes me a second to say, like, if I'm putting these gloves on, something's not going right, or so I'm not doing something right. One of the two things.
Yeah. And it's a challenging thing because there's no package of what clinical supervision is. That we have our package here at this agency. You go next door to a different agency and it looks totally different. I grew up in agencies, we didn't have a clinical supervisor. You were just kind of out doing, and hopefully nobody noticed when you mess things up. But here we are, we're watching. So I think it's an awesome concept. Like, I am jealous of the job you get to do that we're building here that you fit to fill. Man, I want to do that job. Like, it sounds pretty fun. So, cool. That is a great lead into this discussion because we're not talking about procedural things in our discussion today. We're not talking about technical application. We're talking about decision points here and the knowledge and the understanding we need to have in making those decisions, which again comes to you that we're trying to instill this in providers, but provider hits kind of a stuck point and it's, I'm not sure how to take this piece of information. That's you.
Yep.
You get for you. Well,
get to know just a little bit more to make sure we can get past those humps.
Any nerves being that phone call in the middle of the night when it rings and it's
been 2.5 years and I've only accidentally not answered one phone call in the middle of the night. So far I'm doing pretty good.
All right.
Not too many nerves. I feel like I'm pretty comfortable with it.
All right. So like you said, we're talking about levofed is going to be part of our discussion, norepinephrine, and I just want to give levofed a little bit of love. That levofed, leave them dead.
Yeah.
Whole thing, that it fell out of favor because it kills people. Okay, well, we're talking about dying people receiving this medication. So you could put that to any medication. You could give Zofran to the patient that's about to crash. Like, Zofran kills everybody. How dangerous. Right? That's the knowing better and looking at the research a little bit better is like, oh man, maybe the person with a systolic blood pressure of 30 that got levofed wasn't really in a good zone to survive that to begin with.
Right.
And I think that goes into we'll make some of these points, but recognizing shock is crucial. Recognizing it, intervening in it, and early enough. Anyway, let's not give away the farm here. Norepinephrine and epinephrine are two vasopressors we're carrying here in Sugarland. Give us a quick just review of what makes these things similar and what makes them different.
So both medications work on the alpha-beta receptors in the body. Norepinephrine mostly focuses on the alpha receptors, like all the vasculature that the alpha receptors do. both work on the beta receptors, but epinephrine versus norepi, it really hits hard on those beta receptors, really hits hard on the heart, really hits hard on the lungs. And so when you start kind of differentiating when to use it, you start looking at different compensating mechanisms. It's like, hey, if I need to hit that heart or those lungs, need to really address them, then I'm going to use that epi. If it's just like I need to really tighten up that blood pressure, tighten up that vasculature, then I'm going to go ahead and use that norepi.
All right, so very similar. Not entirely interchangeable, but not that far off from interchangeable, right? Yeah. And I like the way I like to talk about it is that both can be good choices, and there's circumstances that one's better, but it doesn't. It's not a night and day difference, not two sides of a coin kind of thing.
Right.
So shock management with vasopressors. I'm going to say this now so that we can say it a couple of times. If we're giving somebody vasopressors, there's got to be fluid in front of it. Don't clamp down vessels with nothing in it. Don't make the heartbeat harder with nothing in it. Right? We just cavitate the pump, make sure it's primed, we get some fluid in there. Whole nother discussion of volume of fluids that we put into somebody. Fluid first. Fluids and pressors. I like keeping things simple. So what's our ultimate definition of shock, Jake? What's in the textbook?
Yeah, the simplest aspect of it is inadequate tissue perfusion or end organ perfusion. So basically, just if you think of it, the furthest tissue away is always pointing to the fingertips. That little fingertip is not getting oxygen for whatever reason. Blood's not flowing to it, and it's starting to die. And so that's shock. So anywhere in the system where oxygen is not being delivered via the blood, you start to have that death of tissue, that lack of perfusion.
And I love thinking of it that classic way, that clinical way, because then you start asking why. I mean, they're not, end tissues aren't getting perfused. Well, why? Right? There's a variety of reasons why, but therein lies our treatment decisions.
Yeah.
Classically, old way of thinking. What does shock look like? What are we taught to look at in vital signs that say, hey, shock?
Oh, the old classic shock presentation, like a decompensating shock. It's gonna be a real low blood pressure, a real high heart rate, maybe some altered mental status, and then probably some increased respiratory drive. Like that's going to be your most classic sign of shock.
Right. And what's the next step in that progression from that point that you just described?
Near death to death.
Yeah, you're dead.
Yeah.
But I came out of school, and that's the picture of shock that I was taught in my mind was that low blood pressure, high heart rate. But for the love of God, we're behind the game.
Oh yeah, way behind.
The op tempo is taking off on us big time. And there again lies the value of identifying shock early, intervening early, that maybe there's not all cases of shock needing extreme interventions. We get a little bit and prevent deterioration.
Right.
Another thought to throw with it that we'll talk about is fluid in shock, that AY could be there's not volume in the vasculature to get oxygen where we're going, but it may not because we lost volume, it's just not in the right place.
Right.
So it's a lack of volume in the right place, which definitely goes to some treatment thoughts and treatment decisions as we move through. Just to make this point one more time, Jake, is shock about blood pressure?
Shock has to do with blood pressure, but it's not about blood pressure, right?
Can I have a systolic blood pressure over 100 and have a shock patient?
Oh, absolutely. Congestive heart failure is probably one of the best ones, right? Where you have a high blood pressure or a really normal tensive blood pressure, but yet still be in a very shocky state because that heart is just not beating. Like some of the little things we didn't quite talk about. When it comes to shock, you're thinking of three different major components. The most simple one we always think of is like volume replacement. So the fluid in the system, the typical shooting, stabbing, blood going everywhere, right? That's going to put you in shock. You lose your volume, you lose everything. But the other two components of it, the pipes, which is the vasculature, and the heart, the pump, those two things are what we're really going to be focusing on with these norepi and epinephrine, trying to address those issues, which are going to help us get out of that shock state. And so whenever we start looking at like cardiogenic shock or start looking at a CHF patient, it's the pump that's not working correctly. And so how do we support that pump to then have that fluid flow around as we need it to? Because if the pump doesn't work, just like you know on any fire truck, you're just going to have water and hoses, but it's not going to go anywhere.
So let's dive into shock. Let's talk about shock. Let's start with septic shock. We're talking about septic and cardiogenic today. Spoiler alert. That's what we're talking about.
Two big ones.
So septic shock, very common thing for us to see. Residential facilities, people are living longer than we normally do, blah, blah, blah. Okay, so septic shock. In a nutshell, what's happening to these three components that you mentioned, the volume, the vasculature, the heart, What's happening to septic shock to those three items?
So you get those really sick people. They end up starting to have toxins build up in the bloodstream, and then so you have your typical high urine output, high vomiting, diarrhea, anything that's going to push that volume low. Then you're going to have the toxins that are going to start making the heart not beat effectively. And at the end of it, you're going to have this massive vasodilation from all these toxins in the body. And so you're going to have low fluid, you're going to have a weak pump, and you're going to have big pipes that are too big for the volume that they're going. And so then they're hitting all three components of that cardiac triad.
All right, so this seems like we could throw just about anything in this direction and we'll start hitting at least the right target.
Right.
So since shock is our concern about perfusion in the tissues at the end of the line, when it comes to sepsis, what's this major danger? What's really going to kill people long term when it comes to sepsis and infections?
Just going to be that heart failing, which is then going to have the respiratory drive failing, which is just going to fail all the organs, right? So end organ failure is your the definition of death, and then that last state of shock. And so all the necessary organs, the livers, the kidneys, the lungs, the heart, everything that you need to survive pretty much all starts to die slowly, and then you end up just not being able to make it out of that. That's why sepsis is really important to get ahead of as soon as we can recognize it.
Absolutely time sensitive. And it's that supporting that perfusion, because you're right, like you said, like we went to the end of the line that all organs are dead, but if we back up 2 or 3 steps and we have some organs that are dead, like we're talking about intestines and digestive tract, kind of need that.
Oh, yeah.
Kidneys dying, okay, well now we just created a dialysis patient because that tissue died. That this becomes a major quality of life issue. That not just save a life, but saving a lifestyle kind of stuff.
Right.
Okay, so I got a couple of notes that we make sure we hit here. That sepsis is a pretty frequent thing, more frequent than we may realize. And according to some of these studies here, 1 in 3 deaths in the hospital is a septic case, directly attributed to sepsis. And when we look at our treatments and our effectiveness, the length of hospital stay, length of ICU stay is a profound metric to look at, because the longer somebody's in the hospital, the more likely it is they're going to get infected.
Right.
All right. So we shifted recently to using our QSOFA score on sepsis because it is a measurement of end organ perfusion.
Right.
And a score of 2 or higher is a significantly higher mortality rate because of that. So not only do these organs die, but as they die, they decompose, and here's more and more toxins cyclic down the drain.
Yep.
So, okay, let's talk about supporting perfusion. What's our pressor of choice in sepsis?
We want to look at norepi in sepsis. So we're really wanting to hit those alpha effects, and so we want to get that vascular constriction tightened up so that the pump doesn't have to work nearly as hard to circulate what volume's left, because the pumps are the pipes are a little bit smaller. It's so that norepi is going to hit those alpha effects. Going to have a little bit of that beta on the beta side, so we have a little bit of heart increase in heart contractility. But those vascular constrictions really what we're trying to hope for whenever it comes to using norepi on these sepsis patients.
Yeah, and let's not look at it. We look at it systemically, but we usually think about big vessels. But again, we're talking about sepsis with organs dying. Epi hits real nice on organ vasculature. So we get that support in the organ itself to get the perfusion. I like it. Are there different survival rates between epi and norepi in sepsis management? According to some of the research.
Yeah, some of the research shows that like norepi is going to be a lot more effective due to the lack of the effects onto the heart and everything else, because the heart's already in a weakened state. So norepi is like really going to be the good choice. I would definitely challenge anybody who's trying to like learn the differentiation between the two of them. Go do a little bit of research and study on it out there. There's some really good literature on it, and it'll show you kind of what those effects will look like. We've used epi for a long time with success, and so like it's not a bad choice. We just now are starting to carry a better choice with a more targeted goal, and so that norepi is really where we're going to be hitting with those sepsis patients.
I really like how you said it. We have a better choice now.
Yeah.
We had a good choice, we have a better choice. You're right. We don't, like I mentioned, this length of stay, no real difference between the two pressor choices. Mortality rates, no real difference between the pressor choices, but a profound difference in myocardial irritability.
Right.
So sure, we might be supporting the vasculature by putting these people into a VTAC, VFib, all kinds of non-perfusing rhythms. So great, we supported the vasculature in the organs, but now we shut the pump off and
give them a whole different realm of problems.
Right, whole new issue. So sepsis, yes, nasty. These are nasty people.
Yeah.
And what I'll challenge you with is you get a fever and tachycardia, sepsis. Like there we are. Like you're dealing with a sepsis patient. I'm going to go even a step further. That if you get the tachycardic person with the fever, you're probably dealing with a compensated septic shock patient. If you're not worried about the blood pressure, we'll just call it compensated at that point.
Right.
The time you're worried about the blood pressure, we're behind the 8 ball. Catch up. Right?
And a lot of this stuff, like, kind of what we've always been talking about when we preach is like we want to treat in place. Now's not the time to run to the back of the ambulance and set everything. Like as soon as you see that low blood pressure, that tachycardia, that decreased mental status, like now's the time to act. Because every minute that you delay that thing, just even moving out to the ambulance versus some of these facilities, it gets worse and worse and worse. And so you can do a lot of really good stuff with what we carry in our bags right at the spot where we find them. So it's not always the most conducive to work in, but it's going to be the best for that patient. So let's treat as soon as we find these things and not delay it for anything else.
Absolutely. I agree 100%. Let's prepare for that movement.
Oh, yeah.
I mean, it's going to take a few minutes to move outside, even if it's quick. Usain Bolt took 9 seconds to win a gold medal.
Right.
So, I mean, that's an awful lot more than 9 seconds. Your patient can surprise you with what they're going to do there. Time's important. I'm with you. Let's shift gears a little bit. Let's talk about cardiogenic shock.
Right.
And the fact that it's similar, that we're not losing volume out of the body, but we have a different problem, yes?
Oh, yeah.
Okay, so
The pump's not working for us.
Right. And it blows my mind because it was after school that this kind of progression came together for me, because it wasn't taught this way, that we get STEMIs over there. The next conversation we have is congestive heart failure, and then we end that conversation and we talk about cardiogenic shock, and then we stop that conversation, we talk about cardiac arrest. And somehow these aren't connected conversations at school when like 100% that's what it is.
Right.
Looking at some of this literature, I got it there in the notes, what's our most common cause that we're going to encounter of cardiogenic shock?
MIs are going to be the most common for us, which is funny because after you give your Mona or FONA, which is what you got taught back in school, like it was a sit and wait game. It's just kind of like, there's nothing left to do. Now you're having this massive MI, especially those right-sided MIs, right? So like, low blood pressure, give a little bit of fluid, don't give nitro, and then we're just hoping, crossing our fingers to get to the hospital. It seems like now we have something we can actually help support it a little bit. A little controversial to be given those pressors with maybe an MI patient, but definitely something where we can support and push on.
Yeah, and we can revisit that one. I thought it was really interesting that, yes, inferior wall MI, oh my gosh, don't ever give it nitro because you're going to bottom out, they're going to die, all these things. And now we're finding out that no, there's not all inferior MIs are the same. That's a right-sided problem. And really, we're more likely to see a left ventricle cardiogenic shock problem because the left ventricle does
all the work.
It produces the volume, right? That's the cardiac output. Yep. And therein lies cardiogenic problem, is the heart is not producing cardiac output. It doesn't come from the right ventricle. It's the left ventricle. And yes, right ventricle or right-sided heart failure causes left-sided heart failure.
Chain reaction.
But we're more likely to see it in an MI and in an anterior wall STEMI. So I like that one. We're like, it's in V3 and V4, so we can give them all the nitro in the world because their blood pressure is 110. It's fine. With the patient with a systolic blood pressure 110 and a heart rate of 120, like we're dealing with a shock patient, and you're going to be dealing with a cardiac arrest patient. We just keep loading them with nitro and not paying attention to that.
Oh, yeah.
So, classically, again, high heart rate, low blood pressure. What does it look like differently in cardiogenic shock? Let's tie this CHF to cardiogenic shock.
So the blood pressure is going to be affected because the pump's not working. So, but you may not have that tachycardia that goes along with it because you're going to have a failure of the heart. But you also, it may be failing to the point, or you may have enough volume that even that blood pressure kind of stays almost stable, or it's not in the right spot to work. And so you won't see some of those classic signs. You'll definitely see some of the like altered mental status. You may see some of the sweaty, the pale, diaphoresis, that kind of stuff. But you're not going to get all of those classic 100% like super high heart rate, super low blood pressure. It's going to be these like very nuances of the vital sign differences that are going to cause you to have to be aware that like, okay, this could be cardiogenic shock. Like this is something that's treatable. We should be traveling down a different road than what we're traveling now. Like you got to be a little bit more aware of it.
All right, so let's tie this together. Let's go back to the beginning. What is shock in its most basic form?
Inadequate tissue perfusion.
Okay, if we lose a lot of blood, what do our skin parameters typically look like in that patient?
Very pale, mottled, very, very white.
And we get the STEMI over on the other side. that is the pale, cool diaphragm, crushing chest pain, impending sensitivity, all this stuff. Sounds very similar to this mottled skin, this cool, this diaphragmatic patient. How come they sound similar in that presentation?
Because it is shock, of course, right? And so, like, there's only so many different signs of shock. They all kind of interline.
That's what I love. That hemorrhagic shock in some very rudimentary areas looks like cardiogenic shock, looks like septic shock, looks like neurogenic shock. Like, shock is shock.
Yeah, shock
tissues
is shock,
not being perfused is tissues not being perfused. And then again, that's why I love looking at it, because now we're talking about why. Because the pump's failing. Because I don't have any volume. Because the vasculature just, anyway.
With the caveat being neurogenic shock. It does look a little different, right?
Fair.
So that's the caveat there. But most cases, shock is shock, and they all look the same.
I will give you that one. But again, we take these septic, neurogenic, and cardiogenic. We don't have a lot of consistency in blood pressure, heart rate, vital sign presentations. But skin parameter kind of stuff will look the same in some parts of neurogenic shock. End title, guys. End title. Like, end title's going to tell you a lot about shock state. Whole nother episode. All right. What's our pressor of choice if we had to choose one in a cardiogenic shock? And let's dig a little bit deeper into it. That we have the decompensated end. We now are getting the heart rate coming down. We're getting the blood pressure also coming down. What direction does that point you?
Right. Man, you want to support that heart. So we want to be able to have those alpha effects, get the vasculature tightened down. But we also want to support that heart, get that heart to be pumping a little bit better. And so with epi also affecting those beta receptors pretty well, I think epi is going to be that good choice of medication versus the norepi to kind of get where we want to go. They're going to increase that heart contractility, going to make that heart beat a little bit better, and then also going to give us the vasculature change that we need, and then also get that smooth muscle relaxer as well, those beta 2 effects. And so really looking at epi on that aspect of it versus the norepi side of it.
We typically hear a lot of these concerns about how epi is going to stimulate the heart, make it work harder, increase this oxygen demand, and this is a damaged heart, and we're doing that to it. What kind of thoughts do you have to those concerns as I'm coming back to you when you're, hey, epi in that case? I'm like, wait a minute. What thoughts do you have there?
I mean, they're absolutely valid concerns. It is going to do all those things you just mentioned. Like, that's it. But if we're looking at making the heart function better to keep the patient alive, or cross our fingers and hope that it stays working at the rate it's working without giving anything, I think giving that medication, giving that epinephrine on those cardiac issues, like, it's absolutely necessary. Like, we got to keep this patient working, the patient's heart working at a pace that we can keep them functioning and alive to get them where we need to go. And then once we get to the hospital, then all that definitive care occurs, and then they can worry about the after effects afterwards.
Right. Hope's not a good strategy.
No, not at all.
Right. And let's be clear that we talk about epi in a STEMI. This isn't, I identified a STEMI, you get epi. Right? There's the dying STEMIs. This is the STEMI with a heart rate of 40 and a systolic blood pressure of 60. Right. So
yeah, they're near death as it is, and so I think this is a good opportunity to steer them away from that versus just kind of hoping that maybe a little bit of fluid and that's it.
Right.
Yeah, cross our fingers.
All right. And since you mentioned it, we'll come back to that comment yet again. Yes, fluid before pressors and shock, and classically we're taught this whole, like, their lungs are full of fluid, they're drowning, you can't put any more fluid in them, right? Oh, terrible. We got to give fluid to cardiogenic shock.
Yeah.
Right. And granted, this might not be liters and liters of fluid like we might be looking at in other cases, but yes, we do need to give some small boluses ahead of the pressors. Again, if we're going to make the pump squeeze harder, let's put something in it.
Right. Yeah. Always back to that cardiac triad.
Right. All right. Jake, this has been a fun discussion. This has been a good kind of walkthrough of some of the pressors and their functions and what we're trying to accomplish with them. Do you have any other comments you want to throw in there as we close this out? Some things you haven't gotten a chance to say?
Mostly just, like, be aggressive with them. There's great opportunity to use these pressors for really good outcomes with our patients. We tend to want to not go hard in the paint sometimes with drugs, especially when we start messing with the heart and the vasculature system of the body. But man, in the right case, in the right scenario, picking the right drug, you can absolutely have great outcomes with these patients, but any of these shock patients, just by pushing hard on those pressor usage.
I like it. And really, we got a great opportunity that here we practice our push dose into an infusion model. So you really get an opportunity to see what kind of response you get. That we hit somebody with 10 micrograms of epi and we get a response. It's not a long response. It's not long lived. So if we get an undesirable response, that too, it's not that long lived. So this isn't just, shoot from the hip, have fun, but don't be so timid on it.
Yeah, be calculated, but be aggressive.
And I want to make one last comment that if we're going into pressors, we are on push dose pressors. That shouldn't be our long-term solution. And that's why we went to some of our practices the way we do, that we mix the bag, we draw from the bag, that a couple hits of push dose, and then we should be set up to run an infusion of that.
Yeah, so far it's been working great out in the field.
Awesome. And right. So remember, your push dose is to produce an effect, and your infusion is to maintain that effect. True. Awesome. Jake, I appreciate your time and your energy and being with us today to have this kind of discussion.
Absolutely. Thank you very much for having me.
All right. Thanks for listening in, and we'll catch you next time.